Welcome back, and we have the next plenary lecture on occupational health hazards for surgeons towards a gender-based understanding. And this plenary lecture will be chaired by Dr. Satish Goonesinghe, consultant neurological surgeon attached to the teaching hospital call. And over to you, sir.
Hi, we come to the next plenary lecture of Sri Lanka Surgical Congress 2020, the virtual congress of the College of Surgeons of Sri Lanka. This will be delivered by Professor April Roslani, and it is titled Occupational Health Hazards for Surgeons Towards a Gendered Understanding. Professor Roslani is the current president of the College of Surgeons of Malaysia, and she is a professor in the Department of Surgery, University of Malaysia, Kuala Lumpur. And she is also an honorary fellow of the College of Surgeons of Sri Lanka. Over to you, Professor Roslani.
Thank you to the organizers for the opportunity to speak on a subject that is particularly relevant in this era of the pandemic, as the surgical workspace diversity increases. These are my disclosures relevant to this talk. Surgeons have much in common with professional athletes. We spend many years in training. Of the two Malaysian athletes pictured, Farah and Abdul Hadi, the gymnast, began training at 3, while Pandalela Rinong was already a state diver at age 7, both hitting their peak in their 20s. Malaysian surgeons, similarly, would also have trained for nearly 20 years before becoming consultants. In addition, both surgeons and athletes need to combine knowledge with skills and behaviors, including working with teams in order to deliver optimal outcomes. But the physicality of our work also means that, just like athletes, surgeons can suffer occupational injuries. So much so that such injuries are often shrugged off as being part of the job. But is this really the case? Considering the huge investment that goes into training surgeons, healthcare systems must ensure that they can then remain healthy in order to preserve peak performance for as long as possible. In order to provide healthy work environments, it is important to understand the factors that lead to injuries, whether they are preventable or avoidable, and whether patterns of injury are gendered. The field of occupational health has grown around this concept and encompasses not just the physical aspects, but also psychosocial and environmental safety. And I will address each of these domains briefly, as pertains to surgeons, and highlighting areas which may affect the genders differently. Physical health is impacted by injuries, and the mechanisms by which they are inflicted can be acute or chronic. Acute trauma from poor handling of sharps, unsafe use of energy, or accidents can to some extent be minimized with better training and maintenance of equipment. Such measures are commonly incorporated into training programs and healthcare systems. Less attention, however, has been paid to chronic injuries that often result from poor ergonomics, which I would like to expand on further. Consider handheld devices, which are usually designed to have a standard-sized handpiece. Yet, if you compare the 5th percentile of female and 95th percentile of male hands, as illustrated here, it is easy to see how handling of standard devices can pose significant challenges to those at the lower end of the scale. As an illustration, this is a standard colonoscope. On the left, it is being held by my fellow who wears a size 8 glove, and on the right is my hand, which is a size 5.5. It is obvious that adjustments, such as hyperextension of the first metacarpophalangeal joint, allow functional manipulation of the scope. But, performed repeatedly over many procedures, over many years, overuse injuries are likely to develop. It is imperative, therefore, that device design takes physical variation into account. Reducing the grip angle for approximating laparoscopic stapling devices, for instance, could make it easier to perform a single-handed closure. Indeed, instead of relying on conventional mechanisms which often require two-handed manipulation, powered devices which allow complex maneuvers to occur at the touch of a button are more favorable if costs are not prohibitive. The implications of poor ergonomics, whether postural or device-related, are enormous. In this recent review, as many as 85% of surgeons experienced regular musculoskeletal discomfort. Nearly half suffered hand and finger injuries from endoscopic manipulation. Injuries, including neuropraxia, were related to case volume, duration, proportionality of instruments, and the increased physical load from prolonged static positioning. Worryingly, workplace injuries being common and affecting work in up to 30%, only a fifth were reported. It is easy to see how burnout could ensue, with the resultant economic impact for both the individual and the healthcare system. This diagram illustrates the patterns of chronic injury in surgeons performing minimally invasive surgery. What is evident is that while MIS offers benefits to patients, the impacts on surgeons is less beneficial. Contrast the percentages of injuries in surgeons performing conventional open surgery, and it becomes apparent that MIS is good for patients but bad for surgeons. The use of robotics was initially touted as being able to reduce the injuries associated with conventional MIS. However, the static posture required means that the robot alters the pattern, but not the occurrence of injuries. Further design improvements are therefore needed before MIS can continue to deliver benefits to patients without harm to surgeons. Moving on to environmental factors, we have known for some time that female staff working in the operating theatre have higher rates of infertility and pregnancy complications, such as abortion, preterm delivery, growth restriction, and congenital abnormalities. This was often attributed to such staff being an older cohort and the long hours that they work. More recently, however, environmental hazards such as radiation, surgical smoke, anesthetic gases, and toxic agents such as chemotherapeutic drugs have been implicated. In light of this, healthcare systems should rethink work practices, allowing individualized scheduling and providing sufficient protection against such hazards. Operating theatre practices have come into sharp focus during the pandemic. Concern about disease transmission through leakage of aerosolized particles during laparoscopic procedures is understandable. Using Schlieren optical imaging techniques, investigators have shown that there is significant gas leakage through laparoscopic ports. The image on the left shows intentional release of gas for venting of smoke, while the image on the right shows unintentional leakage during insertion or withdrawal of instruments. Leakage is in fact greater in the latter. Early advice to use lower pressures to reduce leakage has been shown to be faulty, as leakage is actually higher with lower pressures. A recent review by Bogdadi et al. Concluded that laparoscopy during the pandemic can be safe, but that additional precautions are needed, such as the use of HEPA filters of at least 0.1 microns to filter out SARS-CoV viruses which are between 70 to 90 nanomicrons when decompressing the pneumoperitoneum. Procedures such as pipec, which involve intentional aerosolization of toxic agents, utilize electrostatic precipitation to minimize unintended dispersal, as well as utilization of a closed aerosol waste system. Adequate and appropriate use of personal protective equipment is, of course, essential for the protection of healthcare workers and should be tailored according to the transmission risk based on patient and procedural factors. The choice between using an N95 mask plus face shield versus powered air purifying respirators in high-risk cases boils down to user comfort, especially during long procedures. Nevertheless, as seen in the previous slides, available PPEs are often in limited sizes, frequently disadvantageous to the female staff and potentially putting them at risk. Face masks that fit poorly either fail to protect or impede performance, as do oversized gowns and gloves. Conversely, pregnant staff may have difficulties finding scrubs, gowns, or radiation protection aprons that fit in the later trimesters, which may also expose them to higher risks. Finally, psychosocial aspects affecting occupational health have been largely overlooked in the surgical profession, with little in the literature. Nevertheless, it is likely that the impact is similar to that in generic cohorts. In this paper, work injuries were found to be common amongst young employees who perceive themselves to have limited autonomy in the workplace. There was a striking gender difference. Of those who reported their injuries, females were more likely to be disregarded than males. On the other hand, males were more likely not to report their injuries, and this was related to their perceived need to project maturity and masculinity, as well as because of a fear of job loss. Perceptions of masculinity have also been linked to work-related accidents. Health and safety rules were seen as a challenge to masculinity, leading to increased risk-taking and subsequent accidents and adverse events, which more frequently involved men. Both these studies highlight the psychosocial constructs, such as power distance, that limit the effectiveness of health and safety educational programs if the onus is placed solely on employees to ensure their own safety. In summary, we still have a long way to go in providing equitably safe working environments for surgeons. Better ergonomics training and improved device design incorporating feedback from more diverse end users is needed, in addition to a more gendered approach to work safety programs. Thank you.
Thank you very much, Professor Roslani, for that excellent lecture. And I wish to profoundly thank you on behalf of the College of Surgeons for addressing this virtual Congress, the Sri Lanka Surgical Congress 2020. Thank you.